Good morning, everyone. As Dr. Ellen Bogan said, my name is Meredith. I'm coming from the University of Miami. Today, I'm going to be presenting on Schwann cell-derived exosomes for the treatment of peripheral nerve injury. So peripheral nerve injury is noted in approximately 3% of all trauma cases. It's characterized by a loss of cellular and axonal integrity. For the set-in classification of nerve injuries, there's neuropraxia, which is the most mild grade, axonotmesis, which is axonal disruption, and neurotmesis, which is the complete disruption of the nerve. For types of injuries, there's compression injury, which is the chronic focal demyelination, crush injury, which occurs from acute traumatic compression, and transection injury, which is a complete discontinuation of the nerve. For full recovery, the nerve must undergo three main processes: Wallerian degeneration, axonal regeneration, and end organ reinnervation. For treatment of peripheral nerve injuries, repair represents one of the most difficult challenges. The sural nerve is a common candidate for graft repair. However, an additional harvest is needed. There's an area of sensory deficit for the patient and often insufficient donor material. Allografts can also be used to mediate this. However, patients must be on immunosuppressants after. Another option for treatment is the use of conduits. There's first-generation conduits, which are non-resorbable silicone tubes. They're beneficial in smaller gaps. They provide a support structure for regrowth and provide a stable barrier for the nerve. The second-generation conduits are the 3D crystal lattice structure in tubes. They're beneficial in larger gaps and constructed of resorbable material and also biocompatible. Schwann cells are supporting glial cells that are essential for successful nerve regeneration. They undergo transformation after injury. They can facilitate cell growth, division, and new basal lamina synthesis, as well as extracellular support. So to provide some background of the current study we're doing, I'm just going to give you a brief overview of the previous study that came out of our lab in 2021. I was using the new version of the second generation conduit with the aim to investigate the ability of Schwann cells to enhance axonal regeneration and functional recovery. This is a picture of how we load our conduits. We put them into a syringe and pull back to bring up the cell suspension with the Schwann cells. And you can see in the picture below that the GFP labeled Schwann cells are equally distributed throughout the conduit. This picture shows that it's an immunostained longitudinal section of the axonal neurofilaments in red, and you can see the close interaction that they're having with the GFP labeled Schwann cells. In this study, they saw that the conduits with Schwann cells enhanced axon regeneration to a similar extent as within the reverse autograft positive control. They had significantly larger fascicles, greater number of myelinated axons, and increased axon diameter and myelin thickness. They also did some electrophysiology studying. The animals were stimulated percutaneously at 16 weeks with monopolar needle electrodes. They measured compound muscle action potentials. And they saw a correlation between increasing myelinated axon counts and both faster conduction velocity and larger CMAP amplitudes. And axon diameter and myelin thickness were also correlated with faster conduction velocities. They also saw that the conduits with the Schwann cells significantly reduced muscle atrophy, and the autotomy scoring for self-mutilation in rats was not statistically significant. As for the current study, we're looking into exosomes, which are the nanovesicles that are secreted from many cell types. They've been shown to be internalized by axons, increase axonal regeneration, and regeneration after nerve injury. Clinically, they offer a potential major benefits over cell transplantation, as there may possibly be no need for immunosuppression long-term for the patients. So the aim of our present study was to investigate the use of second-generation conduits filled with Schwann cell-derived exosomes, and we compared the conduits with Schwann cells to positive and negative controls and measured with behavioral, electrophysiological, and histological outcomes. For our methods, we used adult male and Fisher rats, and the experimental groups were the Schwann cell-filled conduits, exosome-filled conduits, reverse autograft for the positive control, and empty conduit for the negative control. Our experimental timeline was 16 weeks, and in the bottom right, I included a picture of the conduits that we were using. They were Integra manufactured from a type 1 collagen derived from bovine deep flexor tendon. And you can see in this image the cross section, which shows the 3D crystallotic structure on the interior of the conduit. And as I was talking about before, for the loading, it was done by submerging the dry conduit in a syringe with the cell solution, and you apply a slight negative pressure to draw the cell suspension up into the conduit. As for the operative technique, a 13 millimeter resection of the right sciatic nerve was performed in all of the rats with a repair based on group assignment. And the top, this is the conduit repair. We put typically 3 sutures on each side of the repair, and then in the bottom, the reverse autograft. And for the testing for pain and sensation, we used Von Frey filaments, which are hairs that we would apply to the plantar skin of both hind paws. And then also the Hargreaves test, which is an infrared emitter set underneath the center hind paws, looking at the time it takes for the rat to withdraw their paw. And for autotomy scoring, which is the self-mutilation, which is believed to be a representative of pain in animals, for the first 10 days post-op, we assess daily and then once a week. And the scores would range from 0 to 11 based on the Wall grading scale, published in 1979. And I included some information based on the scoring below, with two or more nails is 1 point, and an injury to each distal half of the digit is scored as an additional point. And we also did electrophysiology. We did it a little different this time. We did bipolar direct stimulation versus the monopolar percutaneous. It was done under anesthesia. A bipolar stimulator was used with 20 millivolts applied, and EMG signals were recorded at the gastroc and TA. We recorded peak-to-peak amplitudes and onset latency in both limbs of the animal. For histology, we used cross sections that were stained with toluidine blue to assess the myelin formation and thickness, and then a stereo investigator software for the counting and determination of the myelin thickness. For the behavioral testing results, we didn't see any significant difference between the groups. This would include the Von Frey, Hargreaves, and autotomy scoring. For the electrophysiology, the amplitudes were lowest in the negative control, which was the empty conduits, and they were comparable in the other 3 groups. We saw a similar latency throughout all the groups, and the dry muscle weight was actually the lowest in our exosome group. For the histology, we didn't see any significant difference in axon count or myelin G ratios, which is the inner axonal diameter to the total outer diameter, between groups. As for conclusions, Schwann cell-derived exosome group did not significantly different from other groups. Compared to the Schwann cell group and autograft group, they were as effective. However, we think there might have been some issues with our empty conduit group. It was supposed to be our negative control group, but it did not significantly differ from the treatment groups. We were thinking maybe the conduit was providing a structural support to the regenerating axons. We also changed up the electrophysiology methods, which could have been a problem with the direct stimulation. Some of the nerves, when we were doing the histology, appeared to be fried. So using more media when we do this next is going to be key. As for future directions, Schwann cell-derived exosomes have been characterized generally, but not in the setting of peripheral nerve injury. It's something that another group at the Miami Project is currently working on, with an in-depth protein analysis and mRNA sequencing. We also didn't look at if exosomes were present at the terminal point of the study. We'd like to investigate the time spent at the injury site, or if they're possibly recruiting Schwann cells or other cells that may facilitate regeneration. Few studies have utilized Schwann cells in peripheral nerve injury. We're currently in our study that we're about to start back in Miami now, we're assessing the ability of exosomes to treat a variety of injury types, including chronic compression. We're also looking at different routes of administration, including IV, direct injection, as well as the conduits. We're also looking at the critical gap length in rodent models, which is thought to be about 10 millimeters in the rat. We're thinking maybe therapies may be more robust with shorter gap lengths. However, they may be harder to determine the effects of what we do versus whether the nerve would have recovered by itself. We're looking at that with functional, electrophysiological, and histological outcomes similar to what I just presented on in our current study. And as I mentioned before, the chronic compression injury model, it's the most common type of peripheral nerve injury. So we're looking at maybe if Schwann cells contain markers for pain, are there greater concentrations of Schwann cells and Schwann cell-derived exosomes after chronic compression injury, possibly reducing inflammatory markers, and are they able to improve pain and functional outcomes after chronic compression injury, maybe even with direct injection to the site or IV treatment, which could provide a non-surgical option for patients. I'd like to thank Dr. Burks and Dr. Levy, the PIs of the lab, our PhDs, Dr. Arante and Dr. Schaefer, as well as all the residents and med students that I work with. Thank you so much to the department for having me for the past week and a half. I've had a great time so far, and I'm looking forward to the next few weeks. So with that being said, I'm happy to take any questions at this time.
Meredith, excellent. Any questions? Just speak out. I can't see everybody. There's 50.
Hey, I really enjoyed the talk. This is Christoph Hofstede. I have a quick question for you. In terms of the Schwann cell-derived exosomes, do we know exactly what growth factors and other cytokines they contain, and what type of quality control do you do when you harvest, the exosomes for the experiments? Do you sort of check them every time, or is there a routine protocol that you make sure that it's sort of, it's repeatability between different experiments?
Yeah, absolutely. So within the Miami project, there is a group that works on the production of the exosomes. I can't speak to the specifics of the quality control studies that they perform. I do know that they get done before we get sent the batches of the exosomes in the suspension to use in our experiments. But as for further information on what they exactly do, I am not quite sure.
Okay. So what type of growth factors do we have in there? Or like what factors, what are the main contributors to that effect?
Mm-hmm. Yeah, I know that's been published on before. I'd have to look into that more. I can get back to you on that as for specifics.
Thank you.
Thank you so much.
Any other questions for Meredith?
Hi, Meredith. Very nice talk. Do you know what's the natural history of the original injury in rats? If they left untreated, what happens to that nerve? Does it regrow or?
Yeah, so I think with the critical gap length, the thought is if it's less than 10 millimeters, the nerve will grow back together to some degree. If it's more than that, they need some sort of intervention. As for if neuromas with the formation or how well they regrow, I think it's dependent on the injury, severity of the injury, and disruption of the fibers within the nerve. But I think so from what I know, majority is based on whether or not it's above or below the critical gap length.
Meredith, great talk. Just quick question. Has there been consideration to doing this study without a gap? Because in reality, a lot of human surgery, there's a nerve transfer or direct repair without the gap, and maybe you would see a signal there in terms of speed of reinnervation or robustness of reinnervation between exosome and non-exosome.
Yeah, that's a great point. What we're working on now is we're doing some gap studies. We're also doing a chronic compression injury where we just open their nerve up and just crush the injury with forceps. But that's an option that we're looking at now, but definitely an interesting point of possibly being able to look at the robustness of exosomes in non resection models.